I'm Dr. Richard Finn, a medical oncologist at the Geffen School of Medicine at UCLA. So liver cancer is an interesting cancer because we know who's at risk for it. 90% of patients who develop liver cancer have underlying liver disease. And given that our treatment options are greatest when we find the disease early, including curative approaches, really most specialty societies recommend screening for liver cancer. When I say specialty societies, I mean things like the American Association of Liver Disease and other global liver organizations. And so there's been a lot of studies done on the best way to screen patients. And at this time, ultrasound is felt to be the most appropriate, and doing that every 6 months. Now, there's some caveats there. Ultrasound is very operator dependent, and also body habitus can affect ultrasound quality. For someone who is overweight, then probably ultrasound won't be the best way to image them. To be honest, an MRI is clearly the best way to look at the liver. However, that's just not practical for the number of patients who have liver disease and wouldn't be cost effective. But for patients where ultrasound is not available, then either a CT scan or MRI would be appropriate. Typically doing these at 6 months intervals is what's recommended. There's been a lot of debate about the use of the tumor marker or the protein that can be measured in the blood, alpha-fetoprotein or AFP. The challenge with AFP is that only about 2/3 of liver cancers make AFP. So if we rely on AFP alone, you will miss at least 1/3 of these cases, if not more, because it's not clear what is an elevated AFP, how high do we get concerned. Some people have advocated ultrasound with AFP, and I can't say that's wrong, but you cannot use AFP alone. Probably adding AFP to ultrasound might pick up a few more cases. If someone has an abnormal ultrasound, then that definitely needs to be followed up with more definitive imaging, such as an MRI or CT scan. So when do we start this screening? So the recommendations really vary based on the etiology, but needless to say, anybody who has cirrhosis needs to be screened. One of the challenges is how do we know a patient has cirrhosis? So we need to look for liver disease. We need to ask patients carefully about habits. We need to check a patient's labs. Certainly someone who has thrombocytopenia has to raise the flag of underlying liver disease. Probably the most common cause of thrombocytopenia in a medical practice is portal hypertension as a result of liver disease. And you don't need to have a platelet count of 40,000. Someone who's running a platelet count of 110,000, 120,000, that's low. And we need to be able to explain that, and that should trigger an evaluation. Also, patients who come from parts of the world where hepatitis B is endemic, such as Asia or sub-Saharan Africa, should be screened for hepatitis B. And even in the United States, the CDC recommended several years ago, anyone born in the baby boomer generation should be screened for hepatitis C. Remember, we only had a test for hepatitis C in the early 90s. Before that was non-A, non-B hepatitis. And therefore, patients who had blood transfusions or had some blood exposure that they might not even remember could be at risk for hepatitis C. And now hepatitis C is very curable, right? There's very good drugs. And then also, if we know they have hepatitis C, then that would be triggering an evaluation for liver cancer, a screening effort. And that also goes for patients with hepatitis B. Often patients with hepatitis B don't develop cirrhosis, even though they can develop liver cancer. And that relates to a little difference in the biology of hepatitis B versus C. But needless to say, once someone is around 40 years of age, if they have chronic hepatitis B, they should start their screening for liver cancer. It's a little harder, the guidelines for patients who have diabetes or hemochromatosis. However, I do not think it's unreasonable to intermittently look for cirrhosis in these patients, and if they have cirrhosis, then initiate a screening program. And again, that would typically be with ultrasound or ultrasound and AFP, but always an imaging component. And again, the hope of screening is to find tumors early to improve outcomes. One of the challenges for us in the liver cancer space, and those of us who advocate for patients, is still the US Preventive Task Force, the USPTF, which makes a lot of the recommendations for screening, such as mammogram, colonoscopy, etc., do not have a guideline for liver cancer screening. And that's because there's never been very large, well-done studies that show that screening makes a difference in outcomes for a population. But again, many of us in the liver cancer space and those specialty societies recommend ultrasound, because really finding liver cancer early and in a targeted population, i.e. those who are at risk for liver cancer, we think really can make a difference for our patients.